Okay, well, thank you guys so much for coming and to Zoom as well. And thanks, Marissa, for the introduction. Like she said, I'm Madalyn Rosenthal, and I'm going to be talking a little bit about my dissertation research. So, just a little bit overview of what we're going to talk about today. I'm going to do a little bit of background and honestly, a little bit of history of nutrition and medical education. Then I'm going to present a conceptual model and some of the gaps that we see in the research that pointed towards my dissertation research, which is a practice-based nutrition training. And I'll give you a little taste of some of my aims. So to get started, why do we want to talk about nutrition in medical education, right? Why should physicians be trained in this? So at first, we see a lot of behavioral outcomes when physicians talk with their patients about nutrition, patient motivation, treatment satisfaction, and then also clinical outcomes. And because of all of these benefits, we see a lot of organizations recommending practice guidelines about nutrition. And obviously, in order to get nutritionists to talk about nutrition, we need to train them to do so. Let's see, I lost it. I'll just do click. And if you needed another reason to train them, it's now required. So I'm sure a lot of you have heard about SB 25, which is mandating nutrition education in medical schools. And it has an implementation deadline of July 2027. Of course, when we think about implementing something new into curriculum, right, we want to see what already exists. And I think a lot of the times we kind of assume that there is no nutrition in medical education, right? We see a lot of physicians talking about this. And what I want to share with you today is we do have some nutrition in medical education. I'm just going to argue that it's not really being evaluated effectively. And therefore, we're not seeing physicians get all the way to discussing nutrition meaningfully with their patients. Okay, so this is a little history run through. I actually kind of enjoyed looking through like how far back can we go? So nutrition's actually been around since the 1900s. Nutrition in medical education has been around since like around the 1900s. And I think it's kind of inspiring as a nutrition researcher that the priorities in education really follow our scientific discoveries. So we'll see like when we figured out what vitamins were, that was a really big focus of nutrition medical education. Once nutrition kind of shifted towards nutrition research shifted towards like molecular biology, we see those topics getting covered more in the cellular biology concepts of medical school. So there's a little less emphasis. And then around the 60s, we see it kind of shoot back up when we get all this clinical evidence of like, okay, nutrition, chronic disease, prevention, what's going on here? So this sparked kind of a big period in the 70s of sort of like needs assessment and policy. So we see a lot of like cross-sectional data at this point of like, there's no nutrition in medical schools, and policies, kind of all these different organizations here on the right calling for medical schools to implement nutrition. And then by around the 90s, we kind of start getting our first, outlining of priorities, and our first kind of widespread nutrition intervention for medical schools is the nutrition and medicine curriculum. So this is from UNC Chapel Hill. It's like a web-based curriculum that's actually freely available to medical schools. So that was utilized for a long period of time. And we also had the NHLBI and NIDDK, probably like one of our most significant moments, actually introduced the Nutrition Academic Award. So this was giving funding to 21 medical schools to actually incorporate nutrition into their curriculum. So we'll see a lot of like kind of specific interventions at different schools. So yeah, I just thought this was kind of interesting if you want to read more a little bit about it. So there is some nutrition in medical education. But let's kind of fast forward and see, what's kind of the result of some of those nutrition academic awards. What do we have here, right? These are kind of some common approaches that we see. So first, kind of those asynchronous modules, right? A lot of different institutions will sort of host modules about nutrition, and they have started to add a lot more interactive components, right? So they'll have like little patient vignettes and a little bit more engaging online learning. Interprofessional education. So you'll see the term IPE is very common in medical education. And this is both where we have, in the context of nutrition and med ed, where we'll have dietetic interns and medical students learning together, right, in a classroom setting. We'll also have a lot of RDNs actually teaching students as well, right? So there's two different angles there on interprofessional education. And so they're able to learn nutrition concepts from experts. Case-based learning, this aligns with kind of best practice in medical education. And, we'll see this a lot in residency, right? Where they have a case and they're kind of thinking through how to address nutrition with this specific patient. Longitudinal curriculum, that's kind of like the ideal state of all nutrition and med ed, is that we can kind of weave concepts throughout time. So we're building competency over the years. And finally, culinary medicine. This is like really gained a lot of popularity, kind of started its footing in 2012. It's a very broad term. We'll talk about it in a lot of different contexts, but here we're kind of mentioning teaching and engaging medical students in kind of culinary arts and nutrition education to sort of emphasize concepts through like active learning. And this curriculum can actually be like licensed through a lot of schools. So that is becoming kind of a very widespread. So we have all of these very innovative approaches, but what we find when we think about, sorry, I don't know why, there we go. When we look into the literature, we're actually seeing very little evaluation of practice behavior. And so when I'm talking about practice behavior, I mean the literal act of a physician and patient talking about nutrition, right, during an appointment. So I pulled two reviews here. One is focused on culinary medicine, and one is from a review of interventions from the last 10 years. Zero of these studies considered practice behavior, right? And so but in both reviews, they even commented on this as an opportunity.
Oh, really?
Three. One
Oh,
San Francisco.
yeah, I know. Dr. Rao.
Yeah.
Oh, I had no
Pretty on
idea.
my schedule.
Wow. I would have loved to have.
So you know her though.
I know of her.
Try.
She's not going to know who I am. But yeah,
We'll try that.
she's really, I mean, she's stellar is what I'm hearing.
All right, so
She's very
with
strong.
that,
All UCSF.
All UCSF.
there we go.
Chief
I think we're good.
Dozen
I think we're
dozen.
good.
Mhm.
I'll come back.
So
All righty. So the big, you guys
she's
got the
been on
point, right?
some-
So we have these innovative approaches, right?
She was their
But,
program
we need
director
to
for
kind of
about
guiding question, right? Of like, how should we really train our learners to, and I say learners is the medical education to kind of think about medical
Yeah.
students,
She's
residents together.
really-
How do we want to design an intervention to effectively discuss nutrition with patients, right? And this kind of brings me back to behavioral theory and like what I've been trained in a lot of pushing on different levers of behavioral determinants in order to see some change. So I'm going to walk you through a little bit of this kind of concept using a behavioral model. So I know a lot of our behavioral researchers here have probably seen something like this before. A behavioral model is kind of like a framework for us to think through how we want to design an intervention to push behavior change. And there's many different types of models. I'm showing the integrated behavioral model here. This is like my personal fave. I feel like it's got a little bit of everything in it. And with any behavioral model, what we need to do is really think about the behavior that we're trying to target, right? So it starts with a very clear definition of behavior. So for our context here, behavior is talking to a patient about nutrition during the appointment. And one of our strongest predictors of behavior is intention, right? So if you're intending or planning to do something, you're more likely to do it. So when we think about intention, we have to ask ourselves, like, what influences someone's intention? So these three categories are kind of consistently seen throughout the literature. So attitudes is the first one. So how do I feel about nutrition, right? And what are the benefits to the patient when I talk about nutrition, right? That's kind of the idea of attitudes. And when we look at nutrition and medical education, we'll see a lot of the times that attitudes takes a very broad lens, right? So a lot of times they'll be like, do I think nutrition is even important, right? Or, what is healthy eating? Is it important, right? There's a lot going on with attitudes typically. Norms. So norms is both what others expect for you to do, what's your behavior they expect you to do, as well as what are they doing? So in this context, we might think, as a medical student, are my preceptors expecting me to talk about nutrition? Are my patients expecting me to talk about nutrition? Are my peers, institution? Whereas in addition, who else is talking about nutrition? Do I see my attendings or my preceptors talking about it? And as well as my peers. And then finally, this concept of personal agency, this is like a really big one. The idea that, I'm confident doing something and it's within my control to do it. This is where we'll see a lot of self-efficacy, right? Which is a huge precursor in behavior. Right. So those are crucial, but you may have all the intention in the world to do something, but it just doesn't happen, right? Things get in the way. And this is where we see these three bad boys come in, right? So salience of behavior. Is this an important thing to do right now, right? So if I have a patient that comes in with a broken leg, I might not like immediately start talking about nutrition. Habit as well, right? So if you build habits in something, you're more likely to do it. So if you build a habit of talking about nutrition in your practice, it kind of is second nature. And then finally, environmental constraints. We see this very commonly in clinical practice, right? Huge limitation of time, right? A lot of clinicians report that they just don't have enough time to talk about nutrition with their patients. And finally, we have competence. So really what sorry, I got excited about saying the word competence. Knowledge and skills to perform behavior, right? This is like very crucial, kind of like the bread and butter of nutrition and medical education. And in nutrition and med ed, they kind of loop this term into competence, which I like the definition of here, I find really helpful. The integrated ability to use knowledge, skills, and attitudes to perform a task safely and effectively, right? So that's very med ed. You'll see this kind of big term competence here. So these are all of our different behavioral determinants that we can kind of consider when we're designing an intervention. And we see that of the interventions that we discussed previously, as I mentioned, most of them are really focused on knowledge and skills, right? So modules can help with knowledge building. Interprofessional education is also a really great environment for skill building, right? Like role playing with dietitians, learning how they talk with patients. And then culinary medicine really takes kind of like an integrative approach to this and kind of through hands-on skill building and also kind of building some skills in cooking as well. And we see that these interventions are also a lot of the times aiming to improve attitudes, right? And understanding and kind of comfort with nutrition as well. I'd like to also point out that this is something that culinary medicine really focuses on by aiming to kind of build personal skills and awareness of cooking. You'll see a lot of these interventions are actually looking at this behavior. And I point this out because a lot of our research, this is a big outcome of like, are our learners improving their dietary habits? That's a big outcome we see. So obviously we have, in summary, of what we've got out there. We've got a lot going on with knowledge and skills, right? Attitudes. But what about all these other determinants, right? And what are we missing? So we turn down the lights, it gets spooky, right? Ooh, Halloween, right? We can really kind of look at some gaps here, right? So ultimately, from a knowledge and skills perspective, a lot of interventions are not actually focused on the skill of talking with their patients about nutrition, right? That is like a big gap that I want to point out here. So for example, you might learn a lot about nutrition knowledge in a module, but if you're not actually practicing on applying it to talking to a patient, any dietitians in the room know this, right? That first time you're trying to talk to a patient, it's like a little bit awkward. It's a little bit different to actually communicate that. We also, when it comes to evaluation perspective, we also don't really see these skills totally assessed. Sometimes it'll be in the objective structured clinical examinations, which are kind of the patient simulation tests that a lot of medical students do, but it's usually just like a checkbox of like, they talked about nutrition, but not really getting into like what they talked about. The other thing I like to mention is that content is not always considering time, right? And thinking about the time aspect that a provider actually has an appointment. So you might have an interprofessional education course where students are learning a lot about taking a diet history, right? That is a time consuming process that a lot of physicians may not actually be able to do in practice. So they're learning something that isn't always feasible to conduct when they're seeing patients. Moving to the next, right? So we kind of go back and think about our intention precursors. We see a lot, like I mentioned, this is usually very broad in medical education. We don't see a lot of focus on really honing in on the potential impact of a physician. There's a paper I like that talks about how physicians tend to acknowledge that nutrition is important. The barrier there is that they're like, it's so important, but like it's so vast, right? There's food access, there's food insecurity, there's so many things that I can't control. So it feels overwhelming. Like, what am I supposed to do? Whereas if we think about the idea of, we know from behavioral science, right? The impact a physician can have on motivation and really encouraging that patient to seek out those other resources. And this idea of treatment efficacy comes up, right? So how much as a physician is my conversation with the patient going to impact their health behavior? And we'll come back to this a lot. From a norms perspective, we rarely see this assessed like at all in nutrition and med ed. We also see very little preceptor modeling, right? So our physicians themselves weren't trained on nutrition over the time, so they're not modeling it. And that's kind of like the whole point of residency, right? And how a lot of the kind of structure of how medical school is set up. There's a term called the catch-22, and they talk about this a lot with like, our trainers need to be trained so they can train the new trainees, right? It's a lot going on. And then I'll give a little treat at the bottom. There's my treat for self-efficacy, because a lot of studies do at least measure this and recognize that this is an important thing to think about. And finally, almost done with the scary stuff. As a reminder, those 3 points are very important to build intention, which I don't really see assessed a ton in the papers that I've reviewed. And then finally, that bit I mentioned about actually measuring behavior. This is really challenging. I'm not going to say it's an easy thing to do, especially for learners, because they're often like at different clinical sites. There is a little bit of work with chart reviews, I will say, in some other papers I've read, but this can be very minimal. So in summary, I would say from a content perspective, we see very limited skill building in patient conversation. Any skill building we do have is not usually aligned with practice barriers of time, right? We're not really considering how short of amount of time physicians have. And then from a methods perspective, we don't see any studies really assessing all of these behavioral determinants. Studies we do have are usually kind of limited in their design, right? We have few experimental studies or comparative designs, which, as researchers, we always know is crucial to really assess impact. And then finally, like I mentioned before, we're not really getting a ton of evaluation on skills and practice behavior. So this is my overview, what has happened, what's the scene, that's the gaps that I'm seeing here. I'm going to now transition and talk a little bit about my dissertation research and how I think it's addressing those gaps. But we can't forget what brought me to my dissertation research, right? And so I'm sure a lot of you are familiar with Nutri. This is our point of care software that helps practicing physicians discuss nutrition in an appointment, specifically using collaborative goal setting, which is a short, kind of a brief behavior change strategy that they can leverage in an appointment. So the idea here with Nutri is that physicians will pull up an appointment. During an appointment, they can pull Nutri up on their laptop and walk through a goal setting discussion with their patients. And I want you to think about Nutri as also kind of a behavioral intervention for physicians as well. So all those points that I mentioned previously from our behavioral model, we're also trying to push on those when we think about how Nutri works. So for example, I'm just going to kind of walk you through what Nutri is for those in the room that don't know. Nutri starts off, it has an automated assessment feature. So patients complete a diet recall before their appointment, and Nutri sort of prioritizes goals for the physician so they don't have to go through assessing a ton of information. This is really pushing on environmental constraints, right? It's a big time saver. Our second screen allows patients and providers to kind of engage in a goal setting discussion and using some shared decision making. And throughout this interface, there's little pop-ups of additional knowledge. So say a physician's talking about whole grains and they're like, oh, what's a good definition of whole grains? They're able to click into the software and pull that up to help the patient and kind of set a goal together. And again, this is kind of intervening on that like hard nutrition knowledge, like knowing what's there. And then finally, Nutri has a documentation component. So physicians are able to document what actually happened in this discussion, as well as a patient handout. And again, this is also kind of looking at environmental constraints and time saving. So shout out to Nutri. We overarchingly hope that Nutri is going to build physician self-efficacy or confidence in talking about nutrition. So again, this intervention is something that kind of inspired the medical education work that I've been doing. So the idea here is that we took the spirit of Nutri, right, and developed, you like the spirit, Halloween, it's cute, and developed a didactic training for medical students and residents. So the key points of our training are treatment efficacy, that's a typo. So treatment efficacy, right? As a physician, talking about nutrition and talking about it in a way that's just focused on one aspect is going to increase patients' like confidence and ability to change their behavior, right? So rather than saying a bunch of nutrition information and giving a bunch of recommendations, just focusing on one achievable goal, right? So that's kind of a key point of our training. We also ask physicians to, and honestly familiarize them with evidence-based resources, mainly MyPlate, right? MyPlate. And so that they're able to access these during their appointment and also share them with their patients afterwards. And then we also emphasize a lot about documentation. And this is for a couple of reasons. First, it's really helpful to follow up and with the patient if you have a clear note of what you discussed last time. And a lot of the times nutrition, we're not sure what it looks like in the chart. So this can help with patients in maintaining their behavior. Also, it can help with reimbursement, right? So hopefully we're going to push on that and trying to improve reimbursement. So again, these 4 points are kind of the kind of take home messages that we have in our training. And we also always give our learners like an opportunity to actually practice diet goal setting, right? And like I mentioned, doing it in a short amount of time. So with that, this is kind of the background of my dissertation. And my first aim is to really evaluate this training approach on precursors to diet counseling and practice. So that conceptual model that I shared, we're going to measure how this approach impacts those. So to do this, we had a sample from Del Med. So this is our second year Del Med students that are the beginning of their 2-year-long primary care clerkship. So the primary care clerkship is where they rotate. Every student's assigned to like a different primary care clinic, and they will rotate in that clinic. They'll go once a week over 2 years. So they're going to this clinic a lot of the times. And we conducted our training during one of their didactic half days. So while they're going to clinic, right, they'll go to clinic, but sometimes they come into the classroom and learn some key concepts that they can apply in their clerkship. So we delivered our training in October of last year, and this was at kind of the beginning of their clerkship. So they've been to a couple times of their clinics, they know what's up, but then they received our training. So they were randomized to our Nutri training are delayed intervention. So they were split into two groups and then they did one or the other. We surveyed them and then they switched. And the delayed intervention content was just a review that had nothing to do with nutrition. And quickly on the learning activities, like I mentioned, it's going to hit on those concepts that we talked about in the prior slide. But we also brought in some awesome senior medical students. If any of them are on, they're all residents now. They call themselves the Burger Boys. The Burger Boys helped lead this training. I did a lecture that talked about kind of the concepts, like I mentioned, and then we had a role-playing activity with Nutri. And what I want you to think about here is Nutri was really as more of a interactive way to engage with content as well as the goal-setting framework. And so, yeah, so this is a lot on a slide, but just follow me as I go through it. So like I mentioned, our survey is going to really mirror our conceptual model. So when it comes to attitudes, we really focused on that treatment efficacy concept. This is from a validated survey that came actually out of the Nutrition Academic Award. For norms, like I mentioned, not really assessed. I adapted an item that was based on kind of like weight loss counseling. And you can see these are the different kind of key stakeholders that we asked about, right? Like, how do your patients feel about you talking about nutrition? So that's our norms question. Competence and skills, like I mentioned, is like huge. And so we chose to measure this in two different ways. First is the NutComp measure. So NutComp is like the largest survey for outpatient nutrition care. So it's used kind of, I think they wrote an article, it's been across like many countries. So it's very widely used. And we also added another assessment that we really like to focus kind of on skills. And you can see I provided the scale here. There'll be a list of different kind of skills or competencies. And the respondent will actually indicate how confident they are performing these skills. So we kind of get a little bit more than just like agree, disagree. When it comes to personal agency and intention, these are really simple questions that we also have actually used in Nutri. So, do I have confidence in having an effective discussion? Do I have confidence the patient can leave with a diet goal? And then do I intend to talk to my patient about diet? So these are our survey measures, and we'll continue to come back to them. So I'm happy to answer questions later on. From my analysis, so what I did was a linear regression of treatment effects. So that would be which group you were in on each of the constructs at post-test. I also ran a sensitivity analysis that controlled for baseline, and we saw similar trends. I just am reporting the post-test here owing to randomization, and we have a larger sample size. I also went ahead and included percent difference between group means so that we can really kind of see like the pattern of change that we're seeing here just from a descriptive perspective. All right, who's ready for results? Woohoo, yay, it's been a minute. Alrighty, so first results here, kind of looking at self-efficacy and intention, which we know are really crucial precursors. We see our Nutri students indicated greater self-efficacy and intention to discuss diet. So you see along the bottom here, we got 25% greater self-efficacy for an effectiveness discussion with your patient, and then 13% greater intention. And I'll point out, these are my effect sizes here. We're on a scale of 1 to 5. So looking at these other precursors, we see significantly greater competence, skills, and treatment efficacy attitudes in Nutri compared to control. We don't see as large of an effect on our norms around nutrition care measure. And if you go back to that measure, obviously kind of by design, it's got a lot of like heterogeneity going on because it's asking a lot of different people. And we just average this. That's kind of how it was used in the measure from the literature. And so in our intervention, we really only intervened on peers, right? Because we had those senior medical students discussing nutrition, sharing how they do it in their clerkship. So this might kind of point us to an implication of needing an intervention on a little bit more levels of influence, ecological model. And you guys know I made a big fuss on practice behaviors. So I at least wanted to show, I was kind of wanting to do a little bit of an exploratory analysis here. And I mentioned that our students are actually rotating in clinics for their clerkship. And so as part of their clerkship, they actually have to report the patient logs of patients they see. And this is actually for like monitoring and accreditation for the school that they're getting their mandatory clinical experiences. So they already are doing this as part of their training. And so what we did was we actually reviewed these patient logs. And the way they work is that the log will be like, what is kind of a presenting scenario of this patient and what did you do to intervene? And there's a lot of check boxes, right? There might be some extra notes, but there's check boxes of what they did to intervene. So what we did for this analysis was we looked at all of the patient logs that had a chronic disease condition. So hypertension, hyperlipidemia, diabetes, and obesity. And we pulled those and then we looked at the proportion of sessions where the students checked motivational interviewing / goal setting or nutrition counseling. So we did 2 different ones there. I did do a third looking at both, but it wasn't a very big sample. And so we actually compared the proportions at 1 month pre-training and 1 month post. So I know that this is probably making everyone ask lots of questions, but I want to highlight that this is like really a feasibility thing as well. We had no idea. Like when I talked to the clerkship director, so like we've never pulled this and done something like this before. So what I'm really trying to demonstrate here is that we even see data and how much we're getting at this 1 month period of time. And so what we find here is, and one more point, we are not assessing the difference between the 2 groups, right? Because they were trained on the same day. So we're just looking at kind of a pre-post evaluation. And what we see here is that our student documentation of the motivational interviewing or goal setting doubled from a group perspective pre to post training. And we don't see that change in nutrition counseling. So again, this is like very feasibility, but trying to see what we're pulling here. I suspect that, these are like essentially medical students that aren't running the session, right? They're following and attending. So they may not be able to specifically choose to discuss nutrition, but perhaps they felt more comfortable with like the goal setting framework and incorporating that in their discussions. So again, this is like kind of exploratory, and hopefully we can kind of use just a little bit of this data to inform design of future interventions. So with that, kind of takeaways of this study is that our nutrition training indeed affected precursors to counseling behavior. There's some more work that we need to do with norms. Perhaps we could think about training the preceptors, right? With this training, so it aligns, and even maybe incorporating Nutri, right? Because that is the spirit of it. Ding, ding, that'd be cool. And our future work can really assess impact of practice behavior. So I'd love to like design a study that more critically looks at that from the chart review. And this manuscript has been submitted to the clinical teacher, which is a medical education journal. So we'll see what they say, go from there. So yeah, so this is awesome, right? We got to see, this makes sense, right? It worked. Like the way we thought about designing the intervention, we see the impacts, what we thought, but we got to push it a little bit. Like I mentioned, there's not a lot of comparative effectiveness studies in medical education. So we can't really like fully understand the impact compared to what we're currently doing. So that is kind of this guiding question of like, how does this training compare to typical approaches? And this is where I'm going to move into my second aim, which was to evaluate differences in those behavioral precursors, as well as kind of the perceived practice application of training in a sample of residents who were trained on our Nutri training versus standard nutrition education. For this study, we did a similar quantitative analysis to what I just presented, but we also added like a qualitative bit to really kind of get at like, all right, we just did this, but like, how are you going to apply this to your practice? Like, are you going to? What stuck out so we can kind of guide future nutrition and medical education? So our design here, like I mentioned, we did this study with residents, and our family medicine program and internal medicine program, so 2 different programs, were invited to be in this to get the training. And so we did the training at their didactic half day. These residents are completing outpatient primary care rotations at CUC, which is a federally qualified health center. So they all are kind of in the same clinic. So like I mentioned, we randomized them to a standard training, which was delivered by either Monica Milanovich, there she is, dietitian, or Dagny Larson, who's on there. Hi, my colleague. And both are dietitians. Like I mentioned, this is kind of representing like the classic baseline interprofessional training exercise, right? So this training reviewed, tips on how to take a diet history, also reviewed my plate kind of concepts and specific foods and what an RD does. And we actually pulled this from MedEd Portal, which is like the online resource for medical education. So we did not fully, it's something that has already been out there and evaluated as well. And for our training, we did that Nutri training kind of similar to what I've described previously. The only difference is that we didn't have the medical students there, and we did a modeling activity with a patient actor to kind of showcase how nutrition conversations would work, both nutrition goal setting would work both with Nutri and without Nutri. So we kind of showcased that. And following the training, we gave them a survey, right? That big survey that we talked about. And I'll talk about specifically what questions we asked in a moment here. And we were also interested in diving in and assessing skills. So the second kind of part of this study, we invited residents to complete a simulation activity. So it was a 30-minute Zoom meeting that we had with them, and they kind of practiced diet goal setting with a standardized patient actor, Tanya, aka. And I will present and what we did was we kind of evaluated the skills. And this is my third dissertation aim, so I'm not going to get too deep into it right now. Following the simulated activity, we did an interview, like I mentioned, to kind of get at like, how was this training experience and think about applying it to practice. So for our survey, we did the same measure, similar, a shorter version, but similar measures as before. Same with self-advocacy. We just picked that skill-based assessment. Treatment advocacy, we did an abridged version. It's a little bit different. It's just 3 items. So less time with residents. You got to shorten up the survey. To analyze this, we did a pre-post, right? So we had pre-posts in 2 groups. So to look at differences between the group, we did paired t-test. Within the group, excuse me. Differences within the group, paired t-test. We also did a linear regression of the treatment effect control on each outcome, controlling for baseline score. So that is kind of our between group analysis. We also wanted to just do kind of like a basic training feedback survey. So this is just assess it post-test. And it's getting at some of those important outcomes I mentioned prior. So we did a training satisfaction. We also asked about their confidence immediately, like in relation to the trainings. We're like, I feel more confident after completing this training, underscore. And then also their intention to discuss diet with their patients. And again, similar analysis as prior with that percent difference. So we can kind of descriptively look at the differences in the means. And finally, like I mentioned, we interviewed them. We asked them to kind of, after they completed their simulated diet counseling experience, we asked them to reflect on it and also think about their application into practice. And we did thematic analysis here to kind of see differences. Alrighty, so I want to kind of first show this pre-post survey outcomes, right? So I'm going to start here by looking at our standard group. So when we run pre-post, right, and we look at this is a t-test, right? So we look at the difference pre to post. We can see we have some improvement, right? Specifically on, patient leaving with an achievable goal and improvement in competence and skills, right? And we see some improvement here, whereas, self-advocacy, treatment advocacy, we don't see as much change. So in a typical evaluation, this is like kind of the results, right? That you'll have a training do. So like we trained them and they improved, right? That's what typically is out there in the literature. But when we put that side by side with another study, right? Our Nutri study, we see a lot larger effect size, right? We see a lot larger effect size as a result of our training, or not as a result, excuse me, as pre-post in our training. And you can see when we look at the differences between groups, we're trending towards Nutri. So again, this is kind of what we can really gain from having some comparative research in medical education. I do like to shout out as well the post-training feedback. We're also seeing those same trends from our UME study, where we're having a greater effect in Nutri on, satisfaction as well as self-efficacy. And as I mentioned, importantly, intention to actually talk about Nutri, right? And I think what we kind of found in our qualitative insights is we really were able to dive into this intention and like, what do you plan to do in your practice? So what we see is actually some pretty big differences on how they plan to incorporate Nutri in practice. So what we see in Nutri, they're like, I like this goal setting approach. I feel like I can, implement it with my patients. Whereas in the standard group, there was this like overall recognition of like, this training reminded me nutrition's an important thing to discuss. But ultimately, time is just a barrier and I'm going to have to just like refer out or give them resources to figure it out on their own. And so I really like this quote from Nutri that kind of highlights that like, yeah, time's always a thing, but now I have something that I can do that I feel like I can feasibly implement. And this also kind of comes back to our like idea of like treatment efficacy, right? Like I can actually do something that's going to impact. So this is like a big question I always had going into this was like, all right, well, they got a tease of Nutri. Are they going to need Nutri in order to do diet counseling? And I was actually really surprised a lot of clinicians. I didn't ask them this, but it came up of, I don't think Nutri is required. And this kind of goes back to the idea of Nutri as like a training tool. And like, it let me see the framework and what I could even discuss with patients. And I think I can apply that. And it's now a way I can engage my patients and allow them to kind of visualize the process. And this, again, kind of leads into this other theme that we found where this goal setting approach is really helpful to organize the conversation, right? As Nutri said, it's like a quality amount of content, a very short amount of time when I engage in goal setting. Whereas in standard, they kind of felt like, okay, I got the first, I'm really good at being like opening it up of, I want to talk about nutrition with you. But when it came into the really specifics of what I should actually change, I didn't know how to talk about that. And this kind of connects to our final point here, where there's just this need for more specific nutrition content, right? Like while you're talking about it, there's going to be some level of like, I need to bring up the specific example or kind of contextualize it for the patient. And Nutri was able to kind of get that from using the software during their simulation. They're like, okay, I had access to something. I was able to fill that gap for myself so we could talk about it as patient. And standard was really calling this out. It was hard to remember specific things. And they had suggested maybe like a summary or an index card I could refer to would be helpful. So this is really, I think this quote is helpful too. It's like, I'm not going to remember this, but if I had something I could fall back on, that would be helpful. And so, in conclusion, kind of what this research tells us is that we see some improvement in both groups, but this comparative design really helps us to nail down in Nutri. And our qualitative insights are really, really impactful to see, like, wow, okay, there's a stark difference in who's going to take this training and run with it. And importantly, practice-based schools will likely need to kind of fill the gap. And so this manuscript I'm drafting up, hoping to get it submitted before the end of the new year. I'm also working on a chart review with CUC to actually look at the differences in counseling documentation between our two groups. It's going to be interesting. I also think it's kind of exploratory, but I think it's going to open up the doors to do more research with CUC, hopefully. That's for Sarah. All right. And then obviously, as I mentioned, this practice tool seems like it could be a really helpful resource during an appointment. So my third aim, which I'm not going to get into today too deep, is, kind of thinking about how conversation changes when we have a practice tool available. So like Nutri, right? And so we can kind of highlight that, maybe, how we can see if there's a different approach when they have this support available. And so from a med ed perspective, this is really just a skills evaluation as well of our training intervention. And so again, that's my third aim. I have coded all the videos and I have some like methods and results drafted. I actually presented the preliminary results at SNEB this past year, but I had to leave a little teaser for a dissertation. So exciting next steps, and I'm almost done. And so I'm really excited, and something that's really relevant in the history of med ed is the ACGB, so that's like accrediting body for graduate medical education, hosted a summit on nutrition and med ed back in 2023. There's Dr. B, she was there. And from that meeting and with collaborations of a lot of other organizations, there's new competencies for nutrition and medical education that are outlined. And competencies drive everything in med ed. So I'm hoping that's going to spark some more research. And there's also a conference coming up in 2026 that is actually focused on what strategies have different medical educators implemented to address these competencies. So hopefully that's something that I'll get to participate in. And then, exciting next steps for me. Like I mentioned, I'm working on my manuscripts. I have a somewhat decent plan to get that done. I've also this past semester been working in Department of Medical Education, facilitating their practice-based learning course. I have like 8 students and we kind of go through case-based learning together. And that's been really cool to kind of see how they learn and how the curriculum is delivered at Del Med. I'm also on the nutrition curriculum working group for SB25. So that I'll have our first meeting next week. And I think that's going to be a really exciting way to kind of bring some of my research to our medical school. And I'm hoping to defend my dissertation next semester and get out of here. I'm just kidding. I'm clearly not leaving. And 10 years UT student. So awesome. And huge thank you, obviously, to my committee, my collaborators. Those are all of the course directors that were involved to logistically make this training happen. Burgermaster Lab and friends. I've got the Burger Boys on there. And then I have to shout out my overgrads, which are known as overachieving undergrads. Isha, who's graduated, and Anna, who is still a student with us. So thank you guys. I'm happy to take any questions. See, cool. Sorry, I'm just making sure I can see the chat as well. Alrighty.